Hi everyone. Since you will be receiving patients directly from the OR, we wanted to give you a quick overview of the types of anesthesia that we use, how to prepare for and monitor these patients, and the most common complications that you may see during the recovery period. Most of this information will be a review for you. We just wanted to present you a summary of the basics of anesthesia and patient recovery.
Types of anesthesia. We use MAC anesthesia, general anesthesia with anesthesia gas, or TIVA, which is total intravenous anesthesia. We use regional anesthesia, such as spinal anesthesia, epidural anesthesia, and nerve blocks. Two major types of anesthesia that we frequently use are MAC anesthesia and general anesthesia. We select the type of anesthesia based on the type of surgery, how painful and invasive the surgery will be, and the patient's clinical condition. So MAC anesthesia, you have varying levels of sedation based on the type of surgery. It can be a patient who's awake, receiving a little bit of local, a little bit of sedation such as Versed, or a very deeply sedated patient getting propofol. The patient is typically not obtunded, still able to move purposefully to repeated painful stimulation, but they're very heavily sedated. They maintain their own ventilatory function, they breathe spontaneously. We always typically use local for these types of cases. No MH triggers are typically used, and no muscle relaxation is used. And the recovery is much faster, typically 30 minutes. There is a much lower risk of post-op nausea, vomiting with MAC anesthesia. General anesthesia, on the other hand, the patient is completely obtunded and does not respond at all to painful stimulation. Their airway is typically unprotected and requires intervention in some way, such as endotracheal intubation, supraglottic device such as LMA, or they can breathe spontaneously at times. Their spontaneous ventilation is frequently inadequate, and they require some kind of support or positive pressure ventilation. Local is also used during these cases. Normally, we do use MH triggers during general anesthesia, such as succinylcholine or anesthesia gas. Recovery time is typically 1 hour, so it's a little bit longer than MAC anesthesia. And there is a higher incidence of postoperative nausea, vomiting when anesthesia gas is used. So with general anesthesia, you can either have TIVA, which is a total intravenous anesthesia, where we use a propofol drip typically, and narcotic boluses or narcotic drip to keep them asleep, versus instead of that, we can use anesthesia gas to keep them asleep. If a patient is intubated, there are two different ways we can extubate the patient after general anesthesia: in the room before bringing them out to PACU. Normally at this facility, we do an awake extubation. This is where we turn off the inhaled anesthetic at the end of the case and wait until the majority of the anesthesia gas is out of the patient's system prior to the removal of the endotracheal tube. Our criteria for awake extubation is the patient has adequate tidal volumes, head lift, follows commands, and has only a small amount of inhaled agent left in their system. Sometimes these patients can be extremely drowsy still and sleepy as soon as we don't stimulate them. They may still come out with a nasal or oral airway in place, especially if they have sleep apnea or have a large body habitus. They may obstruct after they fall back asleep if they are not jostled around or stimulated. If they come out with a nasal or oral airway in place, they are 1-to-1, so do not leave them unattended. And leave the nasal or oral airway in place until they try to remove it themselves. At times, we do choose to pull the airway instrument or endotracheal tube out, put an oral airway in, and bring the patient to you with a full anesthetic still in their system. This is called a deep extubation. This method may be used to prevent them from bucking after a certain type of procedure, such as a hernia repair with mesh. For patient safety, if the patient usually wakes up combative if they have something in their airway, so we remove it prior to wake up. These patients always have an oral airway in place and are on oxygen and are spontaneously breathing. They are, however, obtunded and do not respond to any kind of stimulation. They cannot protect their airways, so do not leave these patients until they wake up. They are completely asleep and must not be touched or jostled around. See, what happens with inhaled anesthesia is that during a full anesthetic, they are in stage 3, which is a very deep level of sedation or anesthesia. While waking up, they go through a stage called stage 2, which is a hyperexcitatory state in which if they are stimulated, they can have a laryngospasm. And after that stage, stage 1, they wake up. And that is where they follow purposeful commands. During stage 2, they may have irregular respirations and obstructions as they go through the excitatory stage prior to wake up. So do not stimulate them until they wake up and follow commands. If stimulated vigorously during this time, they can laryngospasm as mentioned before. After they wake up, they settle down and reorient. Once they wake up, you can pull out their oral airway or nasal airway. If they do laryngospasm, you will notice that there is no end-tidal CO2 or no air passing through the glottis. In this case, it's very important to give them positive pressure ventilation with an ambu bag. You can also give them a jaw thrust while ambu bagging them as well, which helps. At times, you may need to give them a little bit of succinylcholine to break that laryngospasm and relax the vocal cords. Once you note end-tidal CO2 or air passing through the vocal cords, the laryngospasm is gone. Regional anesthesia. There are 3 major types of regional anesthesia that we use: spinal anesthesia, epidural anesthesia, and nerve blocks. Spinal anesthesia consists of injecting a small amount of local anesthetic through a needle in the patient's back into their cerebrospinal fluid. This makes them numb from the waist down. It's a one-time injection that makes them numb from anywhere from 1 to 4 hours, depending on the type of local anesthetic used. We typically use this type of anesthesia for joint replacements and other lower extremity surgeries. So the anesthesia for the case is the numbness from the waist down, because they lose all sensation of pain. However, we do run typically a light propofol drip or give them some Versed in order for them not to hear or remember the surgery. Physiologic effects of spinal anesthetic is a very dense motor block. So their legs are very heavy. The veins and vessels dilate in their lower extremities, so you may see a lot of hypotension and a lot of heat loss as well, so hypothermia. It is best to put a bear hugger on these patients in the postoperative area. They also may need some blood pressure support, such as fluid boluses, medication drips, or other things until the spinal wears off. You can also put their head down, the head of the bed down if the blood pressure drops, which really helps. Epidural anesthesia. For epidural anesthesia, a needle is inserted into the patient's back and a catheter is thread into the epidural space. The local anesthetic is injected in this space and it migrates to the spinal nerves and bathes them with local anesthetic. This makes the patient also numb from the waist down. Medications may be continuously administered in order to provide anesthesia or analgesia to the patient. The patient can be left on the local anesthetic drip through the epidural catheter overnight for pain relief until discontinued by the surgeon. There are several complications with epidural anesthetics, including vasodilation and hypotension and hypothermia. We typically see less hypotension with epidural anesthesia than with spinal anesthesia. However, it can still occur. The patient may also be hypothermic due to the vasodilation, despite efforts to keep them warm intraoperatively with a bear hugger and a fluid warmer. The patient should remain in bed while it is in place. The catheter is secured and clear dressing is placed covering the catheter insertion site. Do not inject any medications or fluids into the epidural catheter. Anesthesia should be called to remove the catheter when an order is placed to discontinue it. If the patient has another rare complication called a wet tap, they may experience a headache, a postural headache, especially upon sitting up, about 24 to 48 hours after the epidural was inserted. So if you do see a patient with these symptoms, just call anesthesia to evaluate the patient. Nerve blocks. For a nerve block, anesthesia is provided by placing local anesthetic medication near peripheral nerves in a desired area using a needle and an ultrasound machine. It may be used as a primary anesthetic or postoperative analgesic when administered in conjunction with general anesthesia. While the block is in place, the patient may have significant numbness in that particular extremity or area where the block was injected. Normally, the block lasts about 18 hours or so it will wear off the next day. Most complications associated with the block are seen immediately postoperatively, so you probably won't see many complications with these. Ketamine. At times during MAC or general anesthesia, we utilize ketamine, and we use it for different reasons. It does have pain-relieving properties, does not decrease respiratory drive, unlike opioids, and the blood pressure is typically maintained when used. We also use it for chronic pain patients because it works on different non-opioid receptors. It has, however, several temporary side effects, such as disorientation, hallucinations, nystagmus, and moaning. If you see any of these postoperatively, the effects will not last long. They will wear off by themselves within 30 minutes or less.
Room setup. It's really important that you have your room set up for your patient's arrival. You must have 2 suction setups, including tubing, your oxygen setup, an ambu bag at bedside. You must have oral and nasal airways at bedside with lubrication. It's always nice to have CO2 monitoring available. If the patient has a CPAP machine, you should have it in the room and ready to go. You want to make sure that you are ready for your patient to come in, so tie up all your loose ends and be ready to stay in the room as soon as your patient arrives. You'll have to be in there to get report, hook up your patient to all your monitors, and you would need to start surveillance of your patient immediately. There are some very common complications that you see in the recovery room. These include CO2 retention, apnea, obstruction, corneal abrasion, post-operative nausea and vomiting, where you'll most likely see it written as PONV, hypotension, hypertension, pain, and hypothermia. CO2 retention. Normally, as CO2 levels increase, ventilatory drive increases. Opioids and anesthetics in the patient's system decreases the ventilatory drive. The more medications and narcotics still in the patient's system, the higher the CO2 needs to be for the brain to stimulate the patient to breathe. Signs and symptoms of high CO2 may include flushed skin, tachypnea, hypertension, confusion, lethargy, agitation, arrhythmias, unconsciousness. As you can see, these can also are signs and symptoms that people have when they're in a lot of pain. There is a temptation at that point to give more narcotics, but you really just need to give less narcotics. So patients who are at risk are patients with sleep apnea, bariatric patients, and the elderly. So patients who have sleep apnea, it's really important to place their CPAP on them if available as quickly as possible to help blow off that CO2 while they're resting. Those bariatric patients, you just need to make sure that they are breathing and that they're not obstructing. Elderly patients are also high risk for CO2 retention because they're often very sensitive to narcotics. So a really important thing to think about, and a really good way of thinking about it is to start slow and go slow when you're dosing narcotics to these type of patients. Apnea. Apnea is a very common occurrence in the recovery room. It can occur with CO2 narcosis. It can occur when CO2 retainers receive too much oxygen. It can occur when too much pain medication is given for the level of the patient's pain. The most common time it occurs in the recovery room is when we've over-medicated the patient. So it's really important to start low and go slow with pain medications, especially with the obese patient. patients with sleep apnea, and the elderly. They are more sensitive to pain medications. Treatment, if this occurs, is to give the patient a jaw thrust to see if this pain stimulation can cause them to breathe. If still not breathing, ambu-bag them until they resume spontaneous ventilation. Insert an oral airway if you have a difficult time ambu-bagging them. Consider Narcan if necessary. It has a lot of side effects. Consider using a non-opioid analgesic like Tylenol or Toradol in the recovery period whenever possible. This can decrease their requirements for opioids and decrease the risk of apnea. These are not medications that are usually going to be on your post-recovery orders, so you will need to call an anesthesiologist to the bedside for orders. Also, I forgot to mention, but it's important that you check the anesthesia record to see if any of these medications have already been given. Oftentimes, especially a firm that has been given during the actual case. Obstruction. Obstruction is extremely common in the post-operative period. Patients with lots of redundant neck tissue, sleep apnea, large tonsils, and a large body habitus often obstruct. Anyone, however, can obstruct. The relaxation from the medications in the patient's system causes the tissue at their pharynx to relax and the tongue to fall backwards in their pharynx. And then I'm going to show a photograph of an obstruction. So, treatment, if the head is flexed with a pillow, remove the pillow altogether. Here we go. A head tilt to one side or the other may cause the chin to open up. A slight chin lift up with 2 fingers can help. A pillow or roll under the shoulders can also help. A jaw thrust maneuver may be utilized where the angle at the back of the jaw pulls forward gently with the nurse's hands. If, however, the situation is simply obstruction, this maneuver can be very painful and stir the patient to flail around and then go back to sleep. And that would cause them to obstruct again. A gentler solution may be more beneficial. Insertion of an oral or nasal airway. So most patients coming to you with an airway will have either a nasal or an oral airway. It's important to know that both of these devices prevent the patient's tongue from occluding the airway. The biggest difference is going to be when you're going to be using them. So an oral airway will only be used on a patient that is asleep. You're not going to be trying to put in an oral airway on a patient who's awake. The nasal airway, while it is more stimulating to insert, once it's there, the patient doesn't notice it, and it will not cause them to gag, which is what the oral airway is going to do.
So this is our demo section. So just a quick recap, if someone is obstructing, you can try tilting their head one side or the other gently to see if that will help to unobstruct them. If that doesn't work, you can give them a chin lift with 2 fingers. You can remove their pillow if their head is flexed by the pillow. You can put a little shoulder roll under their shoulders to see if that will help. If none of that is working and the patient is arousable and semi-awake, the best choice is a nasal airway. It comes in many sizes. Those are sizes 30, 32, and 34. Notice that they're different lengths. Each size up gives a little bit more length. It's really important to select the appropriate length. If it's a little too long, it might tickle the back of their throat and cause them to have a bad experience with it. The selection of the size is by measuring the tip of the nostril to the earlobe, just like that. This is a little long for this gentleman here, who's earless. However, you get the idea. Now, take some water-based lubricant, generously lubricate the nasal airway. Not just a little bit, but a lot, because the turbinates often become damaged if the nasal airway is too dry. So then you would select the most patent or the largest nostril, This one looks a little bit bigger to me, so I'm going to go into that nostril and gently insert the nasal airway. Gently, if you feel any resistance, stop. You can gently wiggle it and insert it into the nair. It is very stimulating to put in, but once it's in, it really shouldn't bother the patient too much. Contraindications to a nasal airway are any patient on blood thinners such as aspirin, patients with low platelets, head trauma, skull fracture, deviated septum, transsphenoidal surgery, or postoperative patients from rhinoplasty or septoplasty. Those patients aren't great candidates for this. Now, there are several sizes of oral airways. The oral airway is most appropriate if the patient's completely obtunded and they don't really have their cough or gag reflex back. So you select the size. We'll hear all the sizes. There you go. You select the size by measuring the corner of the mouth to the earlobe. This would be about the right size for this gentleman. Now there are two ways that you can insert the oral airway. Patients often have their tongues stuck to the roof of their mouths quite often when they're obstructing. So one method I like to use is to put the tongue blade down, to push the tongue down, and then insert the oral airway like this. Just like so. The tongue blade allows the separation of the tongue from the roof of the mouth. Another method that you can use without a tongue blade, if that's not available, is to insert the oral airway upside down to separate the tongue from the roof of the mouth, and then flip it over and insert like this. There you go.
Corneal abrasion. We're just going to talk about a few things that are really common that happen in the recovery room. Every time a patient wakes up, for some reason the first thing they want to do is touch their nose and their eyes. You want to make sure that they don't do that. So be very aware when your patient is first waking up that you're watching their hands. They can very easily scratch their corneas with their finger. Signs and symptoms of a corneal abrasion are feeling like something is stuck in their eye pain, constant blinking and tearing up. Usually it resolves on its own, but it may need antibiotic drops. It's 100% preventable in the sense that if you can stop your patient from touching their eye, they're not going to get it. The next thing we're going to talk about is post-anesthesia nausea. It's really, really, really common for patients to have nausea after surgery. We typically give patients Zofran, Phenergan after surgery. It's really important that you look on your anesthesia record to see what was given by the anesthesiologist and their team during the surgery. Hypotension. Hypotension is also a very common thing that happens post-surgery. A lot of times patients are just recovering from all the medications that were given to them during surgery, and sometimes they just need some time to bring up their pressure again. You can give fluids during this time. You can also lay them flat to help bring up their pressure. Another thing that sometimes helps is we tend to put blankets on patients as soon as they come into the recovery room because it's very cold in the OR. Sometimes that can bring their pressure down too. Sometimes when covering them a little bit will help bring their vasoconstriction back up and bring their blood pressure up also. It's one of those things you just need to watch and manage. So if you cannot get the pressure back up, you definitely need to place a call to the anesthesiologist. Hypertension. It's kind of the same thing. A lot of patients when they're first waking up, they're struggling, they're in a little bit of stress, their blood pressure can go way up. The same thing is when they're just kind of waking up and all those medications are blowing off, they can have some hypertension. Sometimes if you just wait a little while, that will slowly go down as they wake up and become more calm. Another thing that brings people's BP up is pain. So sometimes if you treat their pain, their blood pressure will also go down. The same kind of thing as if the patient is very cold, they also will have higher BP. If you warm them up, those blood vessels dilate and their pressure will come back down. It's another thing that if it's still uncontrolled after all those management items, call anesthesia, because you do not have typically standing blood pressure medication orders. Pain. Pain is the number one thing that we treat in the recovery room. So most likely be what you're treating in the ICU if your patient is becoming awake. They just had surgery. Surgery is always painful. We're mostly treating them with fast-acting medications like fentanyl. We also give Dilaudid, and we give morphine typically for pain. Should be noted that we can give some non-opioids, and there are always a really good option such as IV Tylenol or Toradol, but those things you do need an order from the physician for. Hypothermia. Hypothermia is really common post-surgery because, well, a few reasons. Number one, the OR is really cold. A lot of surgeons don't like to use bear huggers during surgery, so the patients are just overly frozen by the time they get to you. We use bear huggers a lot in the recovery room, mostly for patients who have spinal. As we discussed earlier, spinal anesthesia, the patient can't regulate their temperature through vasodilation and their muscles moving, so they're just very cold, and they will continue to drop their temperature for, I think it's an hour or so after surgery. So it keeps on going down. So you have to just be very aware that if your patient has a low temperature, you need to start warming them up immediately. And if we use a bear hugger, of course, remember to recheck their temperature every 15 minutes. Respiratory distress. So respiratory distress is something that happens very frequently also in the recovery room, mostly because we are pushing narcotics on patients who are already kind of sleepy. Patients come out, they're waking up, they're in a lot of pain. Of course, you want to treat that, but respiratory depression is, of course, one of the side effects of narcotic use. So you just have to be very aware when you're pushing narcotics to watch your patient's respiratory rate and be aware if they're obstructing or if they're not breathing. You have to start using those techniques that we've already discussed. When you first give narcotics, you have to remain at the patient's bedside to monitor how they're going to respond to those narcotics. Sometimes you think the patient is a large person or someone who you feel has a high tolerance for opioids. You push the medication and they immediately go down. So you can't make any sort of judgment about what you think the patient's going to be. You need to stay at the bedside and make sure that they're responding adequately. Less common complications that happen during post-anesthesia are bronchospasms. While they can happen, they just don't happen too often. I'm just going to kind of read through these, and we have some paperwork that we're going to hand out, a handout that goes into more detail about each one of these, but since it's unlikely or less likely that you're going to see them, we do want to mention them, and we don't want you guys to read the handouts, but we're not going to spend a lot of time talking about them.
And Jody Pearson from Ryanadex will be presenting MH to you in just a moment. Any questions, anyone? For any additional questions, please contact Sarah Linkins from PACU. She is offered to support you guys in any way. Just give her a call if you need her. Lisa Woody as well. And for anesthesia questions, you may contact Robert Resnick.
Hello, my name is Jody Pearson, and I'm going to talk with you today about the advances in the management of malignant hyperthermia and the role of Ryanadex. This presentation is made on behalf of Eagle Pharmaceuticals, and as such, the company has provided financial support for this program. Today is October 29th, 2018, and since this will be an enduring piece, educational piece, it's important to review MH periodically and be sure that you are following the up-to-date standard of care and guidelines. We'll start with an overview of MH, or malignant hyperthermia. So As you probably know, MH is a life-threatening disorder of skeletal muscle. And there are certain factors that have to come together in order for malignant hyperthermia to occur. First of all, you must have a susceptible individual. So you need to have a genetic predisposition for MH. And in essence, a little epidemiology here is that about 1 out of every 2,000 to 3,000 individuals carry the defective receptor, which typically is the ryanodine receptor 1. So that person has to be exposed to a triggering agent, and that is certain inhaled anesthetics and or succinylcholine. It's important to note here that this can happen at the first exposure, second, third, fourth, or fifth. It doesn't always happen with the first exposure, and it can be with general anesthesia and or succinylcholine. Then sometimes malignant hyperthermia will occur, and this is a hypermetabolic hyperthermic crisis. And it's imperative that you recognize this early and that the patient receives rapid treatment, as this is essential for minimizing morbidity and mortality. In essence, this is almost seen as important as fire drills. And that's something that you have to be trained on yearly as well. This is a high acuity, low volume event, and that's why this training is so important. This slide here looks at the MH causes, the life-threatening complications that can occur across multiple organ systems. And this was largely based on a study by Larock in anesthesiology, analgesia in 2010. And what's important to note here is that complications are still occurring in up to 35% of MH patients. And those complications that occur with the highest incidence are listed on your left. And that would be cardiac arrhythmia, arrest, and renal dysfunction and failure. More in the middle would be DIC, pulmonary edema, rhabdomyolysis, and then of lesser occurrence would be the compartment syndrome, hepatic dysfunction, and cerebral damage and coma. So you can see it's very important to recognize this is occurring to prevent the incidence of these events. So this slide here really looks at the pathophysiology of malignant hyperthermia. And so we're going to start at the top, and what you see is the first band discusses MH susceptibility. So you have to have that genetically predisposed individual receive a triggering agent, which we talked about was general anesthesia and or succinylcholine. Sometimes they will not have an MH crisis. So this is called variable penetrance. When they do have an MH crisis, the most important thing to remember here is this is a dysregulation of calcium. So when the individual receives the trigger, there is an explosion of calcium. The calcium increases in the myocyte cytoplasm, and this in turn causes a sustained muscle contraction and hypermetabolism. So you might even see the sustained muscle contraction. It could be total body rigidity. It could be a single limb. It could be thoracic rigidity. And it also could be masseter spasm or trismus or lockjaw. So for your post-op patients in the ICU, this could be a patient coming back from surgery who's biting down on their ET tube, who is having increased peak airway pressures. That's potentially a thoracic rigidity. You could go to turn the patient. The patient could be very, very stiff. And this is because the muscles are contracting and they don't stop. And if they don't relax, you will then have rhabdomyolysis, increased CK levels, and as I mentioned, the muscle rigidity. If the rhabdomyolysis is not stopped, hyperkalemia will occur. And this can be severe. This can go 5, 6, 7 on the potassium levels. And that is why, as per the previous slide, you can have the cardiac arrest and cardiac arrhythmias and EKG changes. On the other side of this diagram is the hypermetabolism. So what you're going to see, let's just say in your critical care area with the post-op patient, or even potentially that patient that has a respiratory event, decompensates, and you have to intubate the patient with succinylcholine, you can see these different signs and symptoms could occur. So hyperthermia tends to be a little bit of a later sign, but initially you might see an increase in CO2 production, and this is going to show up on your end-tidal CO2 monitor as increasing. If your patient is not intubated, it could be tachypnea. As that end-tidal CO2 goes up, you could actually maybe even see some confusion with the patient. So whenever you have confusion, you should, one thing you should think about is, what is that patient's CO2 level, and potentially getting an ABG. As this hypermetabolism ensues, there's going to be an increased O2 demand, and you're going to have sympathetic stimulation. This in turn causes the tachycardia. And as the muscle cells continue to contract and they continue to heat up, they consume all the oxygen, all the ATP, and eventually they go into increased aerobic and then anaerobic metabolism. And then you'll see a metabolic and respiratory acidosis. So I think what's important to remember as a critical care nurse, either in the ICU or ER, these signs and symptoms here can look very much like sepsis. And so if you have a patient that's a post-op patient having what I think is really important is this increasing end-tidal CO2, that no matter what you do, that end-tidal CO2 is not coming down, coupled with the tachycardia, coupled with an increasing temperature. And this could start as 99, 100, but then over minutes, you'll start to see 102, maybe 103. At this point, if it's a post-op patient or a patient that you've intubated using succinylcholine, let's just say they had pneumonia, you don't always want to think sepsis. If that temperature continues to go up, 103, 104, when you start hitting 104, 105, and the end-tidal CO2 going up, and no matter what you're doing, you can't get that end-tidal CO2 down, and your APGs are coming back very, very acidotic, you really should always just keep this as a differential diagnosis. And if you don't stop this complex cascade of events, then what would happen is what you saw in the previous slide, but is what's here in this blue ribbon at the bottom here is the cardiac arrhythmias, arrest, pulmonary edema, renal dysfunction, failure, hepatic dysfunction, failure, again, the compartment syndrome, DIC. And when you're reaching 104, 105, 106 temperature, you're having cerebral damage. And again, death is a possibility. So one thing I can't stress enough is the importance of recognizing MH and treating it as quickly as possible. Any delays in the patient receiving the antidote will increase the risk of complications. So this slide right here takes a look at time to administer dantrolene versus rate of complications. Down here on the bottom is the time in minutes. And as you go up on the left-hand side of the graph, it's your rate of MH-related complications. So let's just imagine your patient comes back from surgery. Maybe 20 minutes has arrived on your unit. You go ahead and you get an ABG. The patient's a little tachycardic. You might begin some sedation, perhaps give some propofol, give a narcotic. And you're taking care of this patient, and you notice that the temperature's starting to elevate a little bit. And perhaps you have the patient on an end-tidal CO2 monitor, and you're noticing that the end-tidal CO2 is right around, let's say, 43. So, here you are right at the start, and your respiratory therapist is probably saying, let's wait a little while before we get the ABG because we've just made a vent change. So initially, you might have some interventions take place before you actually even think of it being MH. And so your respiratory therapist may, right over here, 15, 16, 17, 18, 19 minutes later, they decide to get an ABG. In the meantime, you're taking care of the patient, you go to turn the patient, and perhaps when you're touching the patient, you notice the patient's very hot. Well, let's just say the patient had a 100-degree temperature when they came into the unit. When you touch the patient now, you feel like he's starting to burn up. Maybe at this point you're taking let's say a core temperature, a rectal temperature, and it's now 102.5. Well, that might alert you to then think about talking with your intensivist and perhaps getting some cultures, hanging an antibiotic and that sort of thing. The point here is time will march on from the first adverse sign. And once you're at, 20, 30 minutes, you're already at a 30% complication rate. So again, I just can't stress enough, using your voice. This is a team effort, and sometimes it's not real clear if it's MH, but this is something that you should be aware of if the patients have received a trigger. So treating the malignant hyperthermia with Ryanodex or dantrolene sodium. Dantrolene sodium is, again, the antidote for MH. Prior to the availability of dantrolene, which was before 1979, it was not available. There was about an 80 to 100% chance of death. So we've made great strides now. The mortality rate is probably a little bit more, anywhere in the 5 to 20% range. 20% maybe occurring a little bit more at some off-site or ambulatory surgery centers. But there definitely is room for improvement on mortality and the previous morbidity complication you saw of 35%. So Ryanodex is dantrolene, and this is the antidote that you will be administering should you determine if it's malignant hyperthermia. And we're going to go over the dosing of dantrolene and how you would actually reconstitute and administer in a few minutes. So the indication, it's important to mention, is that Ryanodex, dantrolene sodium, for injectable suspension is indicated for the treatment of malignant hyperthermia in conjunction with appropriate supportive measures and for the prevention of malignant hyperthermia in patients at high risk. The supportive measures are many, and one of the first things you would want to do is discontinue use of MH triggering anesthetic agents. So in the OR, they would have to shut off the general anesthesia and not give any more succinylcholine. Perhaps if you're in the critical care area or the ER, it might just be the one dose of succinylcholine for RSI. You wouldn't want to give any more. And if it is a post-op patient, they've already stopped that trigger. Remember, MH can occur. It can occur hours after anesthesia. There have been case reports even a day later, even 48 hours later. So it is important, if you're taking care of a post-op patient and you're starting to see some of these earlier signs and symptoms that I managed, you've got to keep this in the back of your mind, especially if that temperature is reaching such high levels. The patients, as we discussed earlier, will get very acidotic. So you will be managing the acidosis. In addition, you need to cool the patient. So this will basically include ice on all the pulse points, cold IV fluids. You should know where to get cold normal saline, and potentially even a 3-way Foley catheter for irrigating the bladder, as well as a nasogastric tube for irrigation. Taking the temperature down in the room, anything you can do to cool that patient, because they really can burn from the inside out. Lastly, because the muscle cells die, you will see a release of myoglobin, and that is a large protein which will block your renal tubules, and so that can cause kidney injury. And so if this patient is in your ICU, you'll be giving diuretics to prevent kidney injury. So Ryanodex is not a substitute for these appropriate supportive measures that we just discussed. The second bullet here, I think, is very important. It's not always very, very clear that it's MH versus sepsis versus, let's say, neuroleptic malignant syndrome, serotonin syndrome, pheochromocytoma, thyroid storm. There are a lot of other hypermetabolic, hyperthermic disease states. And so it's not always crystal clear that this is MH. As sepsis, as I mentioned, is another hypermetabolic, hyperthermic disease state. And so it's important to know that, I have been asked at times, well, what if you've given Ryanodex and it's not MH? Well, then it's important for you to know what the side effect profile is. And so I'll just read this here. Ryanodex is associated with skeletal muscle weakness, such as loss of grip strength and weakness in the legs, as well as drowsiness, dizziness, dysphagia, dyspnea, and decreased inspiratory capacity. Patients should not be permitted to ambulate without assistance until they have normal strength and balance, and care must be taken to prevent extravasation of Ryanodex into the surrounding tissue due to the high pH of the reconstituted Ryanodex suspension and potential for tissue necrosis. So, a couple important points here. This is a skeletal muscle relaxant. Okay, narcotics, benzodiazepines, those are going to have far more effect on your cardiac and respiratory system. These patients will have to be monitored. They might be intubated. However, we have had patients that have developed MH after the OR in the ICU, and they can present very differently. We had a patient that actually was a couple hours post-op, not intubated, and she started to have some shivers and confusion. She had a low-grade temperature in the recovery area, and so they gave her some Demerol for the shivers, and they decided to give her a little benzodiazepine for the confusion, and the confusion and the shivers resolved. About 20-25 minutes later, she started to have some tachycardia. She got more confused, and she started to complain of some muscle cramps. And then the nurse noticed that her urine was getting a little bit darker in the Foley catheter. And a very astute medical resident, had realized, I don't like the way this looks. Why is she confused? He put an end-tidal CO2 monitor on her. Her CO2 was above 45. He put 2 and 2 together and realized she was having a delayed MH event. They treated her with Ryanodex. She ended up receiving 2 doses, and she never had to be intubated. But obviously, she had to be monitored and had to stay in the ICU for 24 hours. And we'll touch on post-acute phase management as well. Dantrolene, all dantrolene, including Ryanodex, does have a high pH, so you do want to make sure you have a very, very good IV should you have to give dantrolene. So how does Ryanodex work? Well, it is a ryanodine receptor antagonist. And so what does that mean? Well, right here you have a skeletal muscle cell. And this is the ryanodine receptor sitting on the sarcoplasmic reticulum. And when this ryanodine receptor is stimulated by the triggers, it releases all this calcium. These green ions here, these green dots are all calcium ions. And it's released in an uncontrolled manner. And so what Ryanodex does is it inhibits calcium release and helps to reestablish the calcium equilibrium. So that is how dantrolene works. So MHOUSE is the short for Malignant Hyperthermia Association of America. And they recommend the initial and repeat doses of 2.5 milligrams per kilogram. And actually at this point, I think what I'd like to do is I'm going to bring up the malignant hyperthermia protocol here. And hopefully you folks can see this, but this is the algorithm you would follow should MH occur. It's very important. This is an all hands on deck, and you would want to call the malignant hyperthermia hotline immediately. That is a part of every hospital protocol. I'm sure it's yours as well. And you do want to get the MH hotline on, because they will have an expert to guide you through this algorithm. On the left-hand side of this protocol here, signs of MH, we already talked about. I do want to point out that a sudden unexpected cardiac arrest in a young male patient after receiving a trigger would be diagnostic or highly suspicious of MH. So if you ever have a young patient you had to use succinylcholine on and suddenly goes into cardiac arrest, you would want to think MH, as well as trismus or lockjaw or masseter spasm with succinylcholine. That is also a big red flag for MH. And this acute phase treatment here is numbered for you, and basically you want to get help. You want to get the dantrolene. If they're in the OR, you need to stop the surgery. You want to call the hotline. Discontinuing the volatile agents and sucks is the first most important step, and then hyperventilating the patient with 100% oxygen. I'm not going to have time to go through every step here, but I'm just going to point out some of the most important features. Here, step 2, 2.5 milligrams per kilogram is given rapidly through a large bore IV, and Ryanodex on how to administer it is bulleted here at the second bullet. We'll cover a dosing in a minute, and you will repeat until signs of MH are reversed. It's important to know that sometimes more than 10 milligrams per kilogram, up to 30 milligrams per kilogram of dantrolene is necessary. You will be pushing a lot of bicarb for metabolic acidosis, which means your respiratory therapist is going to be getting a lot of ABGs. And you will be cooling the patient as we discussed earlier. You'll start cooling when the temperature is greater than 39, and you will stop cooling when it's less than 38. Otherwise, you will might fall into hypothermia. You will treat dysrhythmias. You will follow an ACLS algorithm if the patient goes into, let's say, VFib arrest. You do always want to avoid calcium channel blockers if you've given dantrolene, because that can cause severe hyperkalemia and cardiac arrest. Patients will get very hyperkalemic, and that is because the muscle cells die. They release potassium, and so you will treat using bicarb, using insulin and dextrose, as well as calcium chloride or calcium gluconate. And then once the patient is stabilized, there's going to be a lot of monitoring of the end-tidal CO2 and blood gases and CK levels and temperature and coags and those sorts of parameters. The patient will have to stay in the ICU for at least 24 hours, and because relapse can occur. And if you look at letter A, 25% of patients will relapse, and the signs and symptoms that we discuss can reappear. In the ICU, the patients will need to get, according to letter B here, bottom left corner, 1 milligram per kilogram IV every 4 to 6 hours of dantrolene, or a continuous infusion for up to 24 hours. Okay, going back to the presentation here. So, Ryanodex is actually an innovative nanosuspension technology. This is a high concentration dantrolene, 250 milligrams is in the one vial, and you will always use sterile water to reconstitute the Ryanodex. We'll go into mixing in just a minute. Moving along here, I'm going to skip a couple of these slides. Actually, let's see. Okay, reconstituting the Ryanodex. The vial has 250 milligrams of dantrolene in it. You will add 5 milliliters of sterile water. That's without bacteriostatic agent. You will give it a little swirl for 5 to 10 seconds. You don't need to shake it really, really hard, otherwise it could bubble up. Just give it a nice little swirl for 5 to 10 seconds, and then you will fill the syringe. This will be weight-based dosing, and we'll review the weight-based dosing in just a minute. Then you will give the Ryanodex via a rapid IV push and follow it with saline. I'm going to back up here for a second. So, real quick, we're going to talk about clinical pharmacology before we go into the actual dosing and administration graph, it's important for you to realize that you will reach a peak plasma concentration in 1 minute. So once you've given the Ryanodex, it will reach the cellular level pretty quickly, and within a couple minutes, you hope to see resolution of the signs and symptoms we discussed. If you do not, you will repeat the dosing 2, 3, 4 times, potentially more, and you will have the Malignant Hyperthermia Association on the line guiding you through that process. This slide right here just discusses some side effects or adverse events that have occurred when using dantrolene or Ryanodex, which is dantrolene. Basically, this dantrolene is a 20 milligram formulation. Ryanodex is a 250 milligram formulation. And you can just take a look down the left-hand side here: flushing, somnolence, dysphonia, dysphagia, nausea. You can just kind of see some of the different side effects and the percent of the time that occurs. Flushing seems to be the highest at 8% as the most common adverse event. We already talked about muscle weakness. Patients, obviously, if they're in your ICU and not intubated, you want to get them up carefully. Tissue necrosis, we already talked about. And obviously, if you're giving patients any other sedatives or muscle relaxants, that could cause the concomitant use of that could make them even sleepier. Again, we talked about not giving calcium channel blockers. We covered mixing, and what I'd like to do now is show you the dosing and administration guide. This should be available for you should your event occur. Typically, it's right there. The dosing guide is right next to the Ryanodex vial. Please, after this presentation, find out where your malignant hyperthermia cart, kit, or dantrolene or Ryanodex is available. You need to find out where the closest location is, because I will tell you that Joint Commission is coming into hospitals, not just the perioperative areas, but they will go into the ICUs and the ERs, and they will ask you, what do you do if you have an MH event? Where are you going to get your dantrolene? So very, very important. Let me just scroll down here to this dosing schedule. So as you can see, this Ryanodex dosage chart has the patient's weight in kilograms, the patient's weight in pounds, and the number of vials to open, and the milligram dosage needed, and how many milliliters you will pull up. We already talked about how to reconstitute it. So this is all weight-based dosing, and it is actual body weight. So if you do have a very obese patient, you will follow this. Also, take note, if it's a 5 kilogram baby, you will be mixing up 1 vial. The baby will need 12.5 milligrams, and you will only be administering 0.25 milliliters. Now, if we scroll down to, let's say, a 150 kilogram patient, which is 330 pounds, you're going to mix up 2 vials, give 375 milligrams, and that will be 7.5 milliliters. It's important to know how many vials of Ryanodex are available to you, because you're going to need to get on the phone with pharmacy and potentially get your backup Ryanodex, because sometimes you need to give a second, a third, and a 4th dose. According to the literature, the average dose needed to get an event under control is around 5.9 milligrams per kilogram. And about 25% of the time, you need to go to 10 milligrams per kilogram. And I am coming up to the end here, and this just will highlight some of the things we've discussed today. So for the treatment and prevention of MH, Ryanodex will allow for a rapid response with 1 vial by 1 provider in less than a minute. This is a drastic change from the low concentration dantrolene, which a dose of for a 100 kilogram patient would take anywhere from 15 to 20 to 25 minutes. and would require mixing by 3 or 4 people. Now with Ryanodex, this allows one person to reconstitute and administer within a minute. As we discussed earlier, stopping the triggering agents and rapidly administering the dantrolene sodium are the greatest priority in an MH crisis, as well as hyperventilating your patient with 100% oxygen. Do not delay in the diagnosis of MH or your risk of complications will increase. Ryanodex is a ryanodine receptor antagonist, and this stabilizes the intracellular calcium dysregulation, which is the underlying pathophysiology of MH. And as we mentioned, it's uniquely formulated to be given rapidly and always in conjunction with your supportive measures. So I think that is the end of our presentation, and I hope you found this helpful.